Sublingual absorption gets used as a selling point across the supplement industry, but almost nobody explains the actual anatomy behind it. Today, I am walking through what the tissue under your tongue and against your cheek can and cannot do with the real numbers. A film placed under the tongue or against the cheek does not need to be swallowed for part of its dose to reach the bloodstream directly. That tissue, the oral mucosa, is a stratified epithelium sitting over a dense capillary bed, and it varies a lot by region. The gums and hard palate are keratinized, tough like skin, built to withstand chewing. The tissue under the tongue and against the inner cheek is different, non-keratinized, thinner, and more flexible, which is also why it is generally more permeable. That thinness is measurable. Sublingual epithelium runs about 100 to 200 micrometers thick across 8 to 12 cell layers. Buccal epithelium inside the cheek is thicker, about 500 to 800 micrometers across 40 to 50 cell layers. Both sit under a mucus layer roughly 70 to 100 micrometers deep. The permeability barrier itself sits in the superficial layers, shaped mostly by intercellular lipids. In keratinized tissue, those lipids seal the surface. In non-keratinized tissue, they are more polar and less densely packed. One structural reason it is more permeable, not simply a matter of being thinner. There are two routes a molecule can take. For the lipid-mediated route, smaller molecules with the right balance of lipophilicity, solubility, and ionization pass through most easily. Polar molecules and macromolecules are instead commonly modeled as crossing predominantly through a separate, more size-restricted pathway, which is where the real sealing shows up. A hindered transport model built mainly on ex vivo porcine Buccal data estimated the effective pore radius of that pathway at roughly 1.5 to 3 nanometers. That is a model estimate, not something measured directly, and it is a big reason most peptides and proteins show poor passive permeability without help. Once a molecule crosses, sublingual and buccal capillaries drain into the deep lingual and facial veins, leading toward the heart, not through the portal vein and liver first, the route every gastrointestinally absorbed compound follows. That is the physiological reason this delivery route exists at all. None of this happens over a large surface. The entire oral cavity offers only about 100 to 200 square centimeters of mucosal surface combined. Sublingual tissue contributes about 26.5 square centimeters, buccal about 50.2, tiny next to the intestine's absorptive surface. Saliva adds a physiological clock. In one study of 159 healthy adults, median unstimulated flow was 0.48 milliliters per minute, with a range of 0.1 to 2. That constant turnover limits how long anything dissolved actually stays in contact with the tissue. Every MIHIYO strip is designed around the same question. Given a molecule's size and properties, how much of a dose has a realistic chance to cross before the rest is swallowed? 5-HTP in our mood boost strip is a relatively polar molecule by published data, properties that suggest limited passive permeability, though that is not the same as measured proof either way. That is the trade-off I keep coming back to in the lab, dwell time versus mouthfeel. We use a 30 to 60 second disintegration target to balance real mucosal contact time against a film that does not turn gummy in the mouth, though whether that window changes absorption still depends on the specific molecule. Oral mucosa absorption is real and mechanistically grounded for the fraction of a dose that stays in contact long enough to cross, but it is bounded by tissue thickness, pore size, surface area, and saliva turnover. Those numbers, not marketing language, determine whether a molecule is a plausible candidate for meaningful transmucosal delivery.